Hi, everyone. My name is Carmen David. I'm an aortic dissection survivor and an aortic athlete.
And I am Jack Crowe. And like Carmen, I'm an aortic dissection survivor, and I'm an aortic athlete too.
We want to thank you guys so much for joining us this evening for a conversation on exercise and aortic disease with Dr. Alan Braverman of Washington University Hospital in St. Louis. But before we get started with Dr. Braverman and his chat, Jack, why don't you let us know what's been going on in aortic athletes?
Yeah, well, Carmen, we're coming up to a year since we started Aortic Athletes. I think we're near 600 members. It's unbelievable, from all over the world, from Papua New Guinea and Africa and just everywhere, and all people with aortic disease of all types. And we did a 30-day exercise challenge before the holidays, so people didn't drink too much eggnog. And we're big into goal setting now. We're into the goal setting stage for the coming year. So if you're not a member of Aortic Athletes on Facebook, we ask you to join. We also encourage you to join our friends here who are sponsoring us at Aortic Hope. And also, if you haven't done so, you can download their brand new patient guide for aortic dissection survivors. I wish I had something like this when I dissected 3 years ago. And I really encourage you to take a look at that, and also join Aortic Hope on Facebook. So join us all. It's wonderful. These are wonderful ways we support one another, and importantly, we get the science that, like we're going to hear tonight. Who's our special guest, Carmen?
Well, we are so pleased to have Dr. Alan Braverman here. He is the Alumni Endowed Professor in Cardiovascular Diseases and Professor of Medicine in the Cardiovascular Division of the Department of Medicine at Washington University School of Medicine. He has special interest in and international expertise in heritable and genetic aortic and vascular conditions such as Marfan syndrome, Loeys-Dietz syndrome, non-syndromic aortic thoracic disease, aortic dissection, and bicuspid aortic valve disease, aortopathy. So all of which are cases that are filled with our aortic athletes group. So the aortic athletes are eager to hear his expertise, and also as he is one of the leading researchers in exercise and aortic disease. So let's turn it over to Dr. Braverman. And to start us off with our talk on, I had thoracic aortic aneurysm surgery. Can I exercise? Dr. Braverman?
Great. Thank you, Carmen. Thank you, Jack, to all the aortic athletes that are tuning in and that will watch this later. Thanks for tuning in. I love to hear about your organization, and good for you. A year and 600 people. That's amazing. And I hope to share what I've learned and what I've learned from you, the people that are so motivated to live their lives like they did before they knew about their aorta, and are living successfully. And they're teaching those of us that try to help you share decisions on making the right decisions with you, and knowing that it's so variable about your condition and where you are, what you want to do, and to try to make common sense out of this. So I'm going to share my screen, give a brief talk, and then we're going to open it up to questions, etc. So let me get past the technical aspects of this, and we'll move on. Yeah, so far so good. Okay, I'm just going to start. So the title of this talk is I had thoracic and aortic aneurysm surgery, and can I still exercise? And I chose this because of a case that I'll present that got me thinking about this more, to try to answer the question. So a few years ago, a patient that I care for asked me if it would be okay for him to participate in an endurance cycling event. And so I said, well, what does that mean? And he said, well, I want to ride my bicycle in a race 700 miles across Spain over several days, about 100 miles a day or so. And I thought, well, yeah, I don't know. Let me think about that. So at age 50, he underwent elective resection of a 50 millimeter ascending aortic aneurysm and aortic valve repair. I'd been following him for bicuspid aortic valve aortopathy. His aorta got large enough and he had elective surgery and did fine, recovered, etc. And he was an athlete, hockey player, etc. And he wanted to do this. And he said, well, doc, am I good to go? And honestly, I didn't really know. And I looked through the literature to try to find out what was the information. And he said, hey, if you don't know, who is going to know? Is this okay? So we spent a lot of time, and actually he set me up to see a website that looked over this information, and an athlete that he was following from Germany that was a triathlete, an Ironman, who had an aortic aneurysm repair and was doing this stuff, pretty intense exercise. And I read about that guy, but what I really read was about a different website altogether, which I'll share in a few minutes, which helped me along this pathway. So what do I think about as a clinical cardiologist and somebody that tries to counsel people and discuss about what they'd like to do after aortic surgery? So there's a lot of questions, and obviously everybody that's listening is going to have a bit of a different story. And so the information is going to be different about what's unique to them and what advice we would give. Why was this aortic surgery performed, and what surgery was performed? Because that impacts the way we think about that. And what underlying condition was present that required aortic surgery? Was it limited, like a bicuspid aortic valve aortopathy, just to the ascending aorta? Or was there a different disorder that affects the entire aorta and blood vessels? And for some people, especially those with genetic aortic conditions like Marfan and vascular EDS and Loeys-Dietz and others, there are features that are away from the aorta that we consider. And also in other athletes, whether it be bone and joint or skeleton or head or coronary arteries, etc., valve disease. And what about medications? Specifically, people that are on long-term anticoagulants such as Coumadin or warfarin because of a mechanical aortic valve that was replaced at the time of the aortic surgery. That might impact certain types of exercise that could involve a risk of bleeding. What's the rest of the aorta like? Is it normal? Is it dissected? Is it aneurysmal? And what about the valve? Is it functioning normally, or are there considerations to think about there when we talk about what exercise is considered safe? And what exercise do you want to do? What's the level? What's the intensity? What kind of training is involved? Did you do it before? And what's the response when you do that to your heart rate and blood pressure in particular? And does this pose a risk? What you want to know, and of course what I want to help with, is does it pose a risk to the aorta with regard to dilatation or aneurysm formation or aortic dissection or rupture in the remaining aorta, depending upon what that's like? So there are a lot of questions to think about when considering exercise. And I think the top line is what I've learned from you, from helping think about this, and from just some of the questions that Jack sent by about what advice that you might be given by your healthcare provider, is really requires shared decision making, because again, there really very little data to guide us in this area. So a lot of consensus and a lot of opinion. And I think it's moving. This target is moving as we learn more and get participation from people like you who want to share your information and share what you're doing and what's happened based upon that. We're involved in a trial right now looking at exercise after aortic dissection with Siddharth Prakash and also researchers at the University of Michigan. And we've finished the one year time frame, and we're collecting follow-up data now on people after aortic dissection are doing, all sorts of exercise and seeing what's happened to their blood pressure and to their aorta and quality of life. So we're interested in this. Okay, two different examples here. On the left of my screen is a dilated aorta of 5 centimeters in a patient with Marfan syndrome who's not yet had surgery and then had surgery for this. And this person had surgery for a type A aortic dissection. So those are different conditions that affect the aorta. There's residual dissection in the person whose scan is on the right, and that has implications for follow-up and blood pressure and things like that. And then what type of operation was performed? Was it a valve sparing root replacement, like in this cartoon, where the valve is resuspended or inside the tubular graft that's shown here? So they have the valve in place, it's just reimplanted, or is a mechanical valve or a bioprosthetic valve inserted into the composite valve graft? So different valves have different implications and different recommendations for management. And probably most importantly is, what's the underlying condition? Is it a disorder that's genetic based, like a heritable thoracic aortic condition that has outward recognizable features? We call those syndromic, like Marfan, Loeys-Dietz, or vascular Ehlers-Danlos syndrome. Or is it non-syndromic, but it's genetic, runs in a family? Sometimes we recognize the gene in about a quarter of the patients where it runs in a family. But we know it's genetic, whether it's a gene positive or negative, because of the family history. These conditions were a bit more restrictive in intensity of exercise and type of exercise, because the whole aorta is involved by the abnormal proteins that affect these conditions. So exercise guidance long-term has to consider this and must, by design, include some restrictions for the most intense things, especially when it's involving resistance exercise, just because of risks involved. And then the special considerations, just like the two hosts tonight, Carmen and Jack, what about exercise after aortic dissection? And I'm sure that anytime that they bring up that they're going to run a marathon to one of their providers, it probably, the first look would be kind of the eyebrows going up a bit to say, what does that look like? Just because, again, of lack of information and the importance of, what does that really mean? And then a topic that I was very interested in is a much more common condition is a bicuspid valve. And what about after aneurysm resection? And this gets to really the first question that my patient asked me: what can I do after this aneurysm's been removed for my bicuspid valve aortic disease? So just to get out, what do you think experts say about exercise after aortic dissection? Again, very little data. We're part of the International Registry of Aortic Dissection, one of the largest data sets in the world, collecting information after acute aortic dissection. And to date, over 13,000 individuals' data are in this data set. This is housed at the University of Michigan. We've been involved in this for about 18 years. And 26 aortic specialists. So these aren't novice. These are cardiologists, cardiac surgeons, vascular specialists that are involved in the IRAD. They were asked to complete a survey about what exercise recommendations do you recommend after aortic dissection. You can see how variable the responses were. A quarter recommended only low impact aerobic, 2/3 up to moderate, 92% no weightlifting or resistance training, half no competitive sports, half no isometric exercise. And the question that you might ask your provider is, well, what's the safe upper limit of heart rate or blood pressure? Well, the responses were all over the board. What the experts considered they would think would be reasonably safe upper limits of heart rate and blood pressure during exercise for people after aortic dissection. So when experts don't necessarily agree on all the very specific granular points, they do agree with general principle. We also wanted to know how people felt after aortic dissection. So quality of life is critical. A lot of people have mental health concerns, anxiety, depression, etc., post-traumatic stress. So we interviewed 300 survivors of dissection about what are they doing, what's their new lifestyle, what exercise are they doing, what's the emotional state, and we got about half the people responded. And not surprising, at least a third of people had very significant mental health concerns with depression and anxiety. A quarter were no longer exercising at all because of the fear that the aorta would just, would not withstand the exercise. A myth, of course, but people can be paralyzed from that concern. And striking, a majority of people were no longer sexually active after aortic dissection because of concerns or about the safety from themselves or from their partner. But most interesting to me and to all of us was those who exercised routinely, those who went ahead and were doing things, of course had less depression, better mental health, and lower blood pressure. So we think exercise is very important for people with aortic disease. Cardiac rehab is low risk for people after aortic dissection repair. There are more and more papers looking at that. We wrote this when there's very little information in a paper over 10 years ago about mild to moderate aerobic exercise after aortic dissection. But really, we have to individualize this. And what I've learned from putting people on treadmills after aortic dissection is you can have a variable response to blood pressure. Some people with hypertension in particular get quite an exuberant blood pressure response. So sometimes it is worthwhile doing that for people to confirm that, yeah, it's going to be fine, or to modify exercise depending upon blood pressure responses. I was part of the writing group of this document that you're probably familiar with. We rewrote the guidelines for managing aortic disease in 2021, was published at the end of 2022 as a year-long project that had lots of specialists from around the country involved. And you can find this online if you look up 2022 guideline for aortic disease management. And important in this document, for the first time, we thought it was really important to emphasize the physical activity and quality of life. And in particular, because many of the patients I was following were not covered for cardiac rehab after aortic surgery, we wanted to emphasize that we thought this was a recommendation with the highest level, class 1. So guidance on people with significant aortic disease about what sort of things you might avoid, like intense isometric exercise, so intense resistance training and burst exertion, etc., emphasizing more endurance and sustained mild and moderate aerobic exercise, and the importance of post-op cardiac rehab for those with aneurysm or dissection surgery, and the importance of 30 to 60 minutes of exercise 3 to 4 days a week for people with aneurysm disease with blood pressure control, and to screen for some of the mental health concerns that we talked about earlier. So these actually went into the guidelines for the first time. Okay, getting back to the patient. Again, my friend who was now in his mid-50s, who said, I want to bike across Spain, doc, tell me if it's okay or not. What do you know? You're the expert. So getting back to that online thing I found about this athlete in Germany, underneath that, I found the story of, okay, before that, sorry, getting ahead of myself. In 2015, so 10 years ago, I was asked to chair this group about writing aortic disease guidelines for exercise for competitive athletes who had aortic disease like Marfan syndrome and others. So this isn't recreational, but this is competitive athletes, high school and beyond, that are competing at the highest levels. And in this specifically, there was no data. So we wrote about this 10 years ago, no data about those who'd had aortic surgery for aneurysm or dissection and then wanted to go back and become part of sports like basketball, etc., competitive. So in Marfan and Loeys-Dietz and familial or genetic conditions, the aorta beyond the root is still at risk for dissection. About 10% or so people with Marfan syndrome might experience a distal aortic event during follow-up, even in the first 5 to 10 years. So there's still concern there, and it has to be restrictive. And there's some concern in bicuspid valve who have dilated aortas distal to the root. But most of the time that's taken care of at the time of surgery. But we emphasize there was no data. So I made it we wrote that it was pretty restrictive and they couldn't return to intense activity after aortic surgery, at least as we wrote in 2015 for competitive athletics. Now, this didn't cover recreational sports, which are different. So looking at exercise for patients with bicuspid valve resection after bicuspid valve aortopathy. So here's a cartoon of the bicuspid valve with the raphe, so the fused leaflet. So there's only 2 leaflets in the anterior, posterior leaflet. And the bicuspid valve has different types of aortic enlargement. Here's a normal appearance of the aorta on the far left. This is a typical one, 70% the ascending phenotype. So that's a dilated ascending aorta. This is a root phenotype, and this is a diffuse aortic phenotype. So my patient had an ascending resection. There's a graph there. His valve remains in place inside. Its aorta was repaired, but his sinuses weren't too dilated. So that's what he looks like. And you say, okay, what about intense exercise? Well, there's a suture line at the end. In the end, are they going to hold up okay with exercise? Is there any problem there? And the rest of the aorta, is it going to be okay? Well, I went to the literature and didn't find much. I went to the lay press because you'd hear about these things. And I found just in Googling athletes and aortic aneurysm, here are the names of 5 athletes that I found that are in the public domain. I don't, that's what they're all in the public domain. So I put them on this chart, but these are professionals. They're at the highest level, NBA stars, NFL football players who've had aneurysm surgery for usually bicuspid valve aneurysm. And one person's still active in the NBA, Jeff Green, and some have retired after a short time, some after 10 years, some were disqualified from football, et cetera, after their surgery or after they had complications. But so there is a little bit of evidence that people have done this sort of intense exercise, but that's it, very limited numbers. So when I read about that, I stumbled across this another website for athletes who exercise after cardiovascular conditions, the Ironheart Foundation. And I found Dave Watkins online, and I read his story and read about his aortic disease, and that he had promised that if he survived what he went through after surgery, he would run an Ironman or do an Ironman competition, and he did. And that became the story of From Flatline to Finish Line, which some of you probably have watched, but it's available on Amazon Prime for, I think it's 74 cents now. It's you can watch this hour-and-a-half long show telling this beautiful story of athletes who went and did Ironman after various heart conditions. Anyway, Dave became a friend, and I told him what I was interested in, and he said, I'll be happy to help you. You can put my data in there. I had aortic surgery, and I've run a triathlon. I'm still exercising, and I can help you recruit. So we recruited from the Ironheart Foundation, and we worked very hard during the pandemic to get medical records and data, and wrote a paper about it. So this is the paper that we wrote. It was published just over a year ago. And it, again, endurance exercise following ascending thoracic aneurysm resection for bicuspid aortic valve. Andrew Lai was a medical resident who then became an aortopathy fellow. He spent a year with me learning aortic disease. And I put him on this project and said, let's finish this up. So he did a lot of legwork getting the data from the athletes and things like that. And then we wrote a paper. And so this case series wanted to examine what happened to the aorta in these athletes who were performing endurance exercise and competition after ascending aneurysm resection for bicuspid valve aortopathy. We collected data from 2019 to 22. The athletes had their surgery from 2005 onwards. So we had a lot of years of follow-up. We recruited them from the Ironheart Foundation and from our university, a data set that I was following. And we collected clinical information, what kind of exercise they were doing, what competitions, and then imaging data from the medical records, from questionnaires and phone calls. And we got the reports about what the aorta was like before surgery, and then what it was what it was like on the most recent post-op study. And this was a typical example. Lou Cookson was still a very motivated athlete. Just talked to him the other day, and at age 65, so 10 years ago, Lou had a valve and ascending replacement for bicuspid valve aortopathy, and he's been competing in endurance athletics for 30 years with half Ironman World Championship, 6th place, Ironman 10th place World Championship. And after surgery, you can see this guy in his 70s. Looks great. He loves this stuff. He does Ironman, triathlons. He's a champion in his age group, etc. after aortic surgery. So those are the people we interviewed for this paper, and we got 21 patients. The average age was 50 at enrollment, and because bicuspid valve disease is 2 to 3-fold more common in men, of course, then we had 80% men. It goes along with the averages, and they participated in this study. And this table from the paper, it just looks at all the 21 people, their decade of age, when they had surgery, what kind of surgery, the aortic size, et cetera, and follow-up, and then all the endurance competitions that you can imagine that were done, and then what happened to people in follow-up. And our results were as follows. So the average average size of the aorta before surgery was, surgical thresholds, about 5 centimeters or so. We had information on 16 of the 21 people for that. And there were some that had to have aortic valve replacement. Most, 2/3, chose a biological valve as opposed to mechanical valve, as you would expect motivated athletes to choose because they didn't want to be on anticoagulation. So they were young for a biological valve, and but that's what they chose. And they resumed endurance exercise or competition on average 6 months after aneurysm resection, some a little earlier, some a little later. And cumulatively, these 21 athletes did 300 endurance events, including, the typical ones and very intense ones. And their exercise protocol was variable, but 16 did 4 to 6 days a week, 5 exercised daily for an hour and a half a day on average. So again, very motivated individuals. And all but one reported that they did not perform any intense weight training. They could do weight training, but it was more moderate or mild, but none were doing intense weight training, basically. And then we found information about what does the aorta look like in these individuals. We had that information in 17 of the 21, and the average follow-up was 6 years after surgery, and it was basically normal. There were some that got up to 4 centimeters or so, but not many. The average was really very modest. And at last follow-up, which was an average of 8 years after surgery, all 21 were still exercising and competing, and there were no adverse aortic outcomes. And that's what we hoped for, and that's what our hypothesis was. That's what we expected. And but it was nice to report that to give people hope. 3 athletes, though, did require a repeat aortic valve replacement for bioprosthetic valve degeneration at an average of 8.5 years after their valve was implanted. And you say, well, what does that look like? That's a little early. And now we didn't have enough words given to us for the paper to have a lot of hypothesis about this. It was that sort of intense exercise. Is that a sort of a red flag, or is that a marker for something to do with the valve degenerating sooner or not? We obviously don't have any information about that, because some people only get 8 to 10 years when they have the valve replaced younger in life, while others get 15 or 20 years out of it. So, but anyway, just something to think about. Okay, so the conclusions, though, from our paper were that participation in endurance competitive athletes after aneurysm resection for bicuspid valve aortopathy involves a shared decision making, and among select individuals. And then these we didn't select the people; they were doing this. We just wrote what they were doing. With isolated bicuspid valve aortopathy and without residual aortic disease, that endurance exercise after aortic aneurysm surgery was not associated with adverse aortic events. So that was the paper. So you can see my interest right now. It is embargoed, so I can't say anything more, but I'm a contributor to Task Force 7, which is rewriting those guidelines that I chaired in 2015. So the AHTV will have a scientific statement in cardiovascular diseases and competition, sports participation. And this section that I'm participating in is on aortic disease and bicuspid aortic valve. There's a Task Force 9 that's going to include information, including aortic disease for masters athletes, which is either variably defined, at least 35 years old. Some people define it as older than that, but still, there'll be information about that that's going to be, you'll be very interested to read about, and I can't say anything more. And I'm going to be a contributor to this work that's going to start in the late spring on cardiovascular care in the tactical athlete, those in the military, police force, firefighters, etc. And that will also include a section on aortic disease and how to manage people who have this as their livelihood. So, Jack and Carmen, thank you for inviting me. We're going to open this up to talk with the group. And the mantra that we say in our aortopathy clinic is protect the tube of life, is what we call the aorta. So I'll stop there.
Well, Dr. Braverman, you know what our motto is? Our motto at Aortic Athletes is don't quit, adapt. So it's kind of similar. You showed that listing of the people who did various endurance events. And I have to tell you, you're responsible for me getting into half marathons and then marathons again, because I saw half marathons on your list and you called it an endurance event, and it had never occurred to me before. I thought, I bet I could jog a half marathon and do it moderately and keep my blood pressure and my heart rate low. And so you're kind of responsible. But before we get to your to some questions about your presentation, I wonder.
Of course.
Okay. I wonder if you could just tell us, like, why aortic disease? What got you started in this multi-decade long journey with our community?
Well, that's it. Thank you for asking. So aortic disease is very personal in the Braverman family. When I was in high school, my father, who was an orthopedic surgeon, experienced an acute aortic dissection, and it took his life. So that was in 1977. He didn't know that he had Marfan syndrome, and it had never been diagnosed for him. And I was one of 6 children in our family, and my oldest brother, David, was 6'4", and the rest of us were just 5'9". I had a twin, another set of twins, and we always blamed it that we were twins, so we didn't get the height. And when I was in medical school, I went into a combined college medical school right out of high school in 1979. I, with the help of a friend and colleague, diagnosed my older brother with Marfan syndrome. So that's what started my family history. And then when I got out of all my training in Boston, I was recruited to WashU in St. Louis, and we started a Marfan syndrome clinic. And we called everybody who had a big aorta Marfan, because there was nothing else to call it 30 some years ago when we started. And what started very modestly as that clinic has grown into one of the largest clinics in the country dedicated to care for people who have aortic disease of all kinds. And I'm so lucky as a clinician to care for people who have these conditions, because they're so motivated to live the best life possible with whatever conditions involving the aorta. So we see people from all over the United States, certainly the Midwest region, with, why is my aorta too big? Why did I have an aortic dissection? And I've gotten involved with the Marfan Foundation, the Montalcino Aortic Consortium, the IRAD, the GenTech Alliance, friends, the colleagues, cardiologists, surgeons all over the world that have like interests, and people like you guys that just share the same zest for how do you understand this condition, how do you live the best life, how do you save your life, and so for me it's personal, and I'm lucky to do it. I've gotten so much from the people I care for, much more than I'll ever give back, just from sharing their experiences. So that's really it. And I've been an athlete my whole life, but not an endurance athlete. And my youngest daughter just ran her first marathon. She's in her last year of law school at NYU, and she said after she started, she said, I'm not just going to read these books and study. I'm going to run a marathon, because the first year she was in New York, she saw the marathon. She said, oh my God, there's hundreds of thousands of people cheering these people on. I'm going to do that. And she'd never been an endurance runner, so she trained for 6 months, and she did her first marathon this fall. We got to go watch her. It was unbelievable. So those of you who do that, the joy you get from doing that kind of stuff. It's unbelievable. And so she shared that, and she did that. She raised money for the Marfan Foundation. She didn't get to, she didn't qualify because she's not an elite runner to get into New York, but she trained. She ran it in 4 hours and 20 minutes, which was great, I thought, for her. She did a great job. She ran a half marathon in Brooklyn. She has some injury. She had some labral tears, which happened afterwards. So she already signed up for Chicago and New York next year. So she's destined that she's going to get back into the running and do that, because she's got the bug.
Well,
congratulations to her. That's amazing.
Go ahead, Carmen.
Thank you.
Carmen, go ahead.
Oh, I was just saying congratulations to her, because that's amazing. I mean, Jack and I know the thrill of all the people in the streets. It's something else, and it's definitely an experience.
Thank you.
Well,
Do you want me to go ahead with a question, Jack, or do you want to go?
go ahead, Carmen.
Well, I'll just jump into some questions here that we have. We know that you said like it's not one size fits all for what the regimen should be for someone, but what role does the stability really play for assessing somebody and whether they should just be, if it's advisable to be on a regimen or not?
It's advisable to do what?
For their stability, like what role does this just having stability play in assessing that they are okay to exercise?
Oh, sure. Okay. So really question is, stability of the aorta. So immediately, so let's just take aortic dissection, for instance. So immediately after an aortic dissection, the aorta is going to be less stable. It can have more friability. It doesn't have the same strength. But the aorta does stiffen up, so to speak, over time. So the first weeks and months after an aortic dissection are probably the first days are the most critical, then the first weeks less so, and over months, things become much more stable. And so the risk of an event to the aorta is much lower. So chronic aortic disease is much different than acute aortic disease. So that would be the first thing in that category, we'd say. So you start much more modestly, like the sort of things you do in cardiac rehab. After a heart attack or after heart surgery, et cetera, we usually start cardiac rehab at 4 weeks, for instance. And so what we've been doing with our aortic athletes, so someone that had an aortic dissection or surgery for aortic dissection, we might start at a very low level at 4 weeks, but really do more intense 3 months down the road, following the blood pressure and things like that carefully in cardiac rehab. So in people that have aneurysm disease, though, so someone has an aneurysm condition, then this, when someone's approaching a surgical threshold, then sometimes we kind of ratchet down a little bit intensities of exercise and things like that. So when we're following somebody who has like bicuspid valve aortic disease, or they sort of get Marfan syndrome, they can be doing things aerobically and things like that. And bicuspid is much less restrictive when the aorta is dilated, because risks of aortic dissection are so low when the aorta is under 5 centimeters in bicuspid valve disease. So that's different than Marfan and Loeys-Dietz and some of the other genetic conditions.
Okay. Well, you did mention about like the rehab also. Do you think that times are changing where doctors are going to try to advise that? I know myself and a number of other people never were sent to rehab that could have helped us along in those, month after or something like that. So is that something that we're kind of gearing towards?
We really hope so. We put in first, education is necessary. So you and others educating your doctors and nurse practitioners, whoever's going to write that order, that said, look, these guidelines say we're supposed to be doing that. It's a class 1 recommendation, which means you're supposed to do it. So if you're not doing it, you have to have a reason not to, and there's a class 1 indication for it. We wrote that very specifically, so it would be in there. And we also wrote it to give momentum for insurance companies to say we're going to cover it, because it's recommended by our guidelines by experts, just like it is in people who've had heart attacks and have had stents put in, et cetera. So, or had coronary bypass surgery. Cardiac rehab's covered if the aortic valve is replaced at the time of aortic dissection surgery, because aortic valve replacement is an indication covered by insurance, but aortic dissection often is not. So educating the population, so the consumer, to say, hey, I've read that I could be doing cardiac rehab. Can I do it? And then for your doctor to say, I think it's low risk for you. Yes, you're stable, et cetera. Let's get you involved. In cardiac rehab, of course, you're going to get your blood pressure monitored, your heart rate. You do things that are really pretty leisurely paced to start and gradually build up over 6 to 12 weeks. People feel better emotionally, physically, especially with aortic disease. There's so much, I think, mental concern because of the way what you've read when you learn you have the condition, what we've written sometimes sounds very frightening. And then you might talk to your provider, who unfortunately may not be educated about what's really low risk and safe, et cetera. So they may be over restrictive because of that person's anxiety about what could happen to you. And then of course you feel it. And as we say, very hard to unring the bell. in aortic disease. Someone rang the bell and said, you can't do this because of this is going to happen. I've had mothers after aortic dissection they say I can't carry my baby because my baby weighs more than 10 pounds. I said, your just heart goes out to someone who's heard something like that because it's very hard to undo that. So we spent a lot of time going over what the real information is and really trying to make sure that what's safe and low risk, and that we have total confidence that it's okay to do this stuff. Now, on the other end, things that are on the highest level, like Ironman and these sort of things, we have no idea what that's really like. And that's why, we wanted to write about it in bicuspid valve aortic disease, because that's a very special group where we know that the rest of the aorta behaves pretty normally. So we wouldn't expect a problem. And so we wouldn't want to be restrictive when it's not necessary. The problem is for so many of these other conditions that we care for, genetic aortic disease, or we don't really know why somebody had an aortic problem, we don't really know. And so then that's why we say shared decision making, because we don't want anybody to get into trouble. In other words, we don't want anybody to get hurt unnecessarily. But what we're learning is that probably being less restrictive is very important for a great number of people.
I wonder, Dr. Braverman, how elastic, in light of that experience, the definitions of moderate and vigorous exercise are, because I think people have different ideas. When I told my nurse practitioner I wanted to run a half marathon, she looked at me like I was crazy and said, "Why on earth would you want to do that?" And I said, "Why wouldn't you? Why wouldn't you want to do that?" Because it was sort of normal. And so, it seems like what's moderate for some people is vigorous for others. For me, I ran the New York Marathon and my heart rate averaged 118 because I had trained that way. So how elastic is the definition?
No, your point is exactly well taken. And, so we really have to do a deep dive into saying, like, what do you like to do? Because somebody might say, I'm not going to do much. And one person that I've cared for had an aortic dissection. And I said, what were you doing? He goes, not that much. I said, well, what does that mean? He goes, like, I was weightlifting. Well, what is it? Not very much. Well, he was doing these 600-pound things or 400-pound things because he used to be doing more than that. So for him, it wasn't as much. And so one person had done like 250 push-ups in a row or something like that. So you say, can I do push-ups? What does that really mean? So your point is well taken. You can see him with exercise, the heart rate response is not the major concern. It's really the blood pressure response because the heart rate doesn't really affect the aortic health. That's just, that's the cardiac output and your training effect and things like that. Some people are on beta blockers, many are, so that can blunt that heart rate response anyway. But some people have a very vigorous blood pressure response. In general, aerobic exercise done at a moderate pace should be just like you said. Heart rate might go up a bit, but then it'll plateau during times where you're still breathing, where you're still aerobic, not anaerobic, gasping for breath and doing things at the highest level you possibly can. When you maintain, usually the heart rate stays pretty constant, but that level, of course, is dependent upon your training and then what's your baseline heart rate and your medications. Whereas isometric, once you reach muscle fatigue, the blood pressure starts going up depending upon how many muscles are used, etc. So you can do modest isometric things, but at the highest level possible where you're straining yourself, even though it's not a high weight, you just reach muscle fatigue and the blood pressure will go up a little bit. So we have these conversations about, what do you want to do? What's practical? Can you do things that are less than most intense, which usually means muscle fatigue, or in competition, usually where you're trying your hardest to do your very best, which is probably what we would say maybe a different strategy is better if you want to do endurance things, bicycling or running, to do things moderately, just like you're doing, where you can still have a heart rate of 116.
Carmen, why don't you ask one more question, and then we'll go to the audience and see what they'd like to ask Dr. Braverman.
Okay. So while you were just talking about the blood pressure, what is the cutoff then during exercise? Is there a certain number or threshold that you would advised to be under?
Yeah, so question is, is there a number? First thing is there's not a number. So, and that's important. And I'm glad you asked that, Carmen, because some people, just like heart rate, will get very concerned if their blood pressure goes over that number. So for instance, if I picked the number and said, I'm just going to make this up, 160, 159 is no different than 161. You see what I mean? If you say, oh, I'm 159, I'm going to maintain this for 12 hours. Right? Okay, that's 12 hours of 159. That's a little bit high. But it's not going to be a problem in people with chronic conditions. It's usually the sudden onset of just an exuberant blood pressure, like we see in people with rare tumors or using cocaine or amphetamines, where the blood pressure goes from 120 to 250. All of a sudden, that causes shear forces on people whose aortas are at risk, and that can precipitate an aortic dissection. So we don't really think about that. If somebody comes in under 120 and they get on our treadmill for our exercise protocol and they walk, at a moderate pace, and we watch their heart rate go up, and we see how fast they're going at 10, 12, 14 degrees, because that's what they're doing, and their blood pressure is 160. We don't say you can't exercise like that. We say you're going to do that for 30 minutes or whatever, that's going to be fine. But if their blood pressure had a hypertensive response, went to 220 or something like that, then we'd have a concern. We'd say, we have to do something differently. Do you have mask hypertension? Are we going to give you an ambulatory blood pressure monitor? Is there something about this exercise that's different? Let's get on the bicycle and see what happens to your blood pressure. Maybe there's something about the treadmill for you that's not the exercise. So that's what some of the beauty is for cardiac rehab right after, because you get a lot of confidence that you don't have that blood pressure response with things that they do in cardiac rehab, bicycle, walking on a treadmill, or walking on the track. Others will say, coming out on our treadmill, we'll do a low-level exercise test and watch your blood pressure. So not a maximal one, but we'll do a low-level stress test.
Sometimes when we do those stress tests, I think they're afraid when they hear that we've dissected. I think that.
No, they are. Absolutely. And it's healthy to have concern, but it's also, so again, if you say, how many papers are written about aortic cardiac rehab after aortic dissection? A handful. So we don't have, 40 years of data, of outcomes data. But there's a world going on now where that's happening, where there are more and more people interested in studying this to show what's the effect, and importantly, is it safe and low risk, so we can give guidance.
But we have a whole group of people who are interested in that and who want to participate in such information. So
excellent.
Yeah, and Joshua, maybe we can go to some questions. I think we have some aortic athletes out there who have had surgery and done some amazing things without dissection, but repair. I think our friend Brad Way is out there, who did the Boston Marathon 6 months after he had an aneurysm repair. He'd done many before, and it was sort of normal for him, and took it really, really easy. But Joshua, what are you hearing out there?
Oh, we got quite a lot of feedback coming in, everyone. This has been a good panel. Thank you so much. Right at the top of the chat, Iris Sweet says, hi, I'm a 2-time survivor who used to run half marathons. What do I have to worry about for someone who used to run 9-minute miles?
Did it say anything? I don't know if that means survivors of aortic dissection or aneurysm surgery, but let's just take it as an aortic dissection anyway at that pace. So one thing I would just say at the outset is we are learning a lot. So I'm going to use this as a soapbox just for a second. We're learning the importance of family history and genetics for aortic disease. So whether we know that abdominal aortic aneurysm is a highly genetic condition where at least 20% of individuals will have a family history. So if you have an abdominal aortic aneurysm, important to screen relatives, so siblings, and then eventually children for the same condition. Thoracic aortic disease is a highly genetic condition, even when it's not syndromic, so not Marfan, it just looks like everybody else, but for some reason the thoracic aorta has been dilated. In bicuspid valves with aneurysms, there's a 10% chance of a relative, a child, of having the same condition. So we screen children with echocardiograms. An unexplained aortic dissection, especially under the age of 60, in somebody without hypertension or severe hypertension, we screen all relatives. So children, siblings, parents, and when we do that, about 20% of the time, we'll see another direct first-degree relative who has thoracic aortic disease or enlargement. And those are the ones that we really look for with genetic testing. Now we do genetic testing in people under the age of 60 with ascending aortic aneurysm, dissection, unexplained dissection, and that can change lives and help prevent things. So I just put that right out there. Okay, so back to the question about I'm a survivor twice. What about my 9-minute mile? So I'd say, like, well, what are you doing now, and what do you want to do, and is everything else okay? In other words, are you exercising now? I would encourage you to. Are you, if not, what about a low and moderate aerobic exercise? If the rest of the aorta is okay and your blood pressure is okay, are you on the bicycle? Are you walking? Or are you doing light jogging? Are you swimming? What are you doing, and how are you feeling with that? And what's the response to that activity? And what's your goals? And then how can we make that congruent? That'd be the starting questions. And the goal would be to try to say, let's give you quality of life doing things that you want to do while you live the rest of your life with best sort of exercise tolerance possible.
I like that. That's a great answer. I want to say hi to Velda. She jumped in to say hi. Karen Anderson, co-founder of Aortic Hope, says, thank you, Dr. Braverman, for being part of the Aortic Hope community. Carmen and Jack, thank you as always. Christian Y, would bicuspid aortic valve be considered syndromic or non-syndromic?
So the vast majority of people with bicuspid aortic valve, it occurs sporadically, and it's not related to a known gene variant. So we don't have a gene panel to say, test this bicuspid valve. But some syndromic conditions like Loeys-Dietz syndrome are overrepresented with bicuspid valves. So instead of 1% of the population having a bicuspid valve, individuals with Loeys-Dietz syndrome have a higher chance of having bicuspid valve, anywhere from about 3% to 15%. So let's just say 8 to 10% of those with Loeys-Dietz will have a bicuspid valve. So individuals, especially younger individuals who have very big aortas with bicuspid valve, especially if it involves the aortic root, we specifically look for, could it be genetic? And we look at their phenotypes. So we look at their skin and their eyes and their skeleton very carefully. But we don't do genetic testing for bicuspid valve aortopathy unless we find features that would suggest an underlying genetic condition or a family history of aortic aneurysm or dissection. Then we might do it. In those populations where there's family history and things like that, the yield's a little bit higher. It's still very low, though. So that's a holy grail. A lot of research being done in large populations. Just a very few number of people with bicuspid valve will be found to have a genetic trait.
Okay.
So it's non-syndromic generally.
Not non-syndromic generally. Thank you, sir. Nisa Nicole says, hi, Carmen. Thank you for organizing this Q&A. Irish Swede says, seems Marfan people like me need to scale things back much more so.
That's we're trying to be reasonable about that, I guess, is what we'd say is we'd encourage somebody with Marfan or Loeys-Dietz to exercise, because we know that bone density is less, quality of life is less, muscle strength is less, and many people are totally restricted upon making the diagnosis. So they can't participate in, little league baseball and soccer, where it's really like a scrum. Those exercises are perfectly safe and low risk with regard to the aorta in young children and young people with Marfan syndrome, unless they have a very special circumstance which was unique to them regarding their eyes or skeleton or aorta or valve. So for routine things, we think that's low risk. The problem is, and this gets into more of the nuance, is some people's aorta is really not that big, and they're very elite athletes, and they're discovered to then have Marfan syndrome, in high school or college, because it just wasn't thought about before. And then you say, now what? And what's the risk of participation in somebody whose aorta is at risk when they, of course, to participate at the highest levels, you have to be able to train at the highest level, and you have to be strong, and you can't, and you have to lift weights and do all these things. That's the challenge, is the acceptance that carries risk, and it's hard. It's not possible to quantify that risk, and many people are willing to take that risk because it means so much to them, even though it could be catastrophic. And that's the challenge that we face, because we never want something like that to happen to somebody, even though it may never happen. That's probably the hardest part of the job.
Thank you, doctor. Let's see here. Paul Kirk says, Dr. Braverman is my cardiologist. He's been a godsend for me and my family. Christian
Nice that you're on. Thank you.
Christian Y says, I see that your studies about athletes exercising after the aortic surgeries were related to endurance athletes. And then there's gonna be another follow-up question to that a little bit down. Ron Tiemann says, outstanding presentation. Christian Y says, I see that your studies about athletes exercising after the aortic surgeries were related to endurance athletes. Do you think that would be similar to athletes for contact sports as well, such as soccer and basketball?
That's a good question. So we think it's probably fine. Honestly, we didn't write about that because that's a different question, but you can see that there's an N of 1 or 2 with NBA basketball players at the highest level after bicuspid valve surgery. And obviously they're banging into each other as hard as you possibly can. So probably fine.
Okay, like to hear that. Ron Tiemann says, hello, Aortic. Larry Giankis says, what about dissections being treated with medication rather than surgery? Are the recommendations different?
So aortic dissections that involve the part of the aorta that arises from the heart, the ascending aorta, are almost always treated surgically, unless the person's not a candidate for surgery because of health issues or something like that. If a dissection occurs in the descending aorta, so distal to the left subclavian artery or down the back alone, and the ascending aorta is not involved, those are treated medically initially unless complications occur or enlargement or aneurysm forms. Sometimes a stent graft's placed for complications, but generally medically, not with open surgery for the vast majority. And all the things that we talked about apply to that group. So medications, exercise, follow-up, goals of life, etc., all apply to what we call a type B or a descending aortic dissection.
So those of us who have the residual dissection on the descending, is there a different calculation for exercise then for those?
No, same. So we really lump those together. In other words, just residual dissection. Now there are a group of people that have had we call it type 2 dissection. It just involves the ascending aorta. It's a limited dissection, and the surgery excises that. The rest of the aorta is not dissected. But the majority of people that experience a type A or an ascending dissection goes all the way around, and they're fixed in the front, and the rest is just watched over a lifetime. And then type B usually just watched. So we treat those groups the same.
Okay. Michael says, thanks for the great presentation. Not too easy to get information on this topic from a lot of cardiologists. Most are very careful with their recommendations. Rick Johnson says, are there going to be any studies on weightlifting versus cardiovascular exercise?
So here's one thing I would pose to the group, and obviously I'll be friends for life with Carmen and Jack. Now we'll be part of your families, and obviously you can reach out to me for questions that I can help with informally in the future. Happy to do that for you guys. But here's one thing Jack, you sent me a list of a dozen people or so that are doing crazy things like you and Carmen are. I was just kidding about that. Things that are just outside of the usual, like I'm going to run a marathon, just like your providers say, like, okay, we'll cross our fingers, hope you're going to be fine because we just don't know. And you do it in a modest pace and you do fine and everything we would hope for. And you say, well, I haven't read anything written about that sort of thing. And just like what we did before, I think there's some momentum about collecting information. And so I'll be back in touch with you guys. And if there is some interest, you could query the various groups to say, obviously it's a very selected group of people that have decided to do this. You're self-selected and you're talking about it, meaning you did fine. So we don't know if somebody had a problem from doing it. All we can do is report what's known. So if you said, well, I've been doing just like we did before. What did you have before? What happened to you? What was your procedure? How is your aorta? What sort of things have you done? And what does it look like now? What's your blood pressure? What are your medicines, etc.? What's your training? That's what we wrote about before. It would be a pretty, obviously it took us about 3 years to do that other project, but you have to start somewhere. So again, gathering information about special groups helps inform what's possible. And so, when I speak to sports cardiologists, experts in the field about what we've written about, they said, we always thought that, but now we can tell people that. I'm showing your slide and it's very empowering in helping us be confident. So, obviously that's the only way you really know about that stuff is the way that is. With regard to, isometric exercise, there of course are reports of, we know that people that do the most intense isometric exercise that are strength trained athletes over time have bigger aortas than those that don't. But if you say, well, does that lead to pathology in the aorta? We don't really know. Most of that information that says, don't do this is based upon theoretical concerns about what could happen to the aorta under intense Valsalva maneuver and at the highest levels of exercise with, blood pressure recordings. You can record blood pressures of 300 millimeters of mercury during the most intense isometric exercise in someone that's reached muscle fatigue at, twice their body weight for somebody who's doing things like that. Those are documented. So he said, well, that may not be a good idea for someone with an aortic dissection because of the theoretical concern about rupture and things like that. And so that's the kind of information that's available. But if you said, what about things more in moderation, and how does that look? Well, that's a study to do. So we usually say try to pick numbers. Again, we try to not to have, you can lift 50 pounds, but not 51, because that's just not helpful. What does that really mean? But some people need hard numbers, and then we work with you to say what's practical, what do you want to do, what's safe, what do we know about it, what kind of risk are we willing to accept, even though we don't really know.
Well, Dr. Alan Braverman, this has been a feast. Our community is grateful both for your interest in Marfans at the start, and now the way you're helping us figure out how we can live our best lives, including through exercise. I can tell you, I think I can speak for a lot of aortic athletes. We'd love to be part of any future studies. Many of us are part of the aortic dissection exercise study. And we know it's up to us to help you guys, get the information you need so that we can advance the message from all cardiologists.
Yeah. Well, it's been a pleasure and a privilege to talk with you tonight and to share my limited knowledge about this condition. And really, I'm going to learn from you. And it's so motivating. It's I just love it. I'll be so energized now to think about projects and to help people, like you said, live the best life you possibly can. And so thank you so much. Privileged to meet with you guys, and thanks for taking the time, and thanks for instigating this.
Okay. Thanks
I know
all.
we had some other questions out there, guys, but we'll try to get those answered for you, or have Dr. Braverman on again so that we can get to those questions, because we know the panel was great tonight. We thank him so much. So thank you for joining us, and we'll see you next time.
Thanks, you guys.